So, when we look at the thoracic vertebra, out of the 12 vertebra, if we have a look from let's say T1 to T12, okay, the T1 is called the atypical, and even the T12 also called the, rather from atypical I will say they were called transitional vertebrae, because the thoracic one vertebra has some features of the cervical vertebra, whereas the last 12th that is T12 vertebra has the, I will be using the term thoracic because that is the anatomical this thing, and you guys say dorsal. So, the last thoracic, that is T12, has the features of the lumbar vertebra, especially when we look at the articulating facets. Okay. The upper facet behaves like a thoracic vertebra, the direction, whereas the lower one is like the lumbar. Now, when we look at there, we again go by the features, that is when we look at the body. So, the body, the transverse and the AP diameter, they again show the variation. In thoracic region, typically the transverse and AP diameters are generally same. When we look at the ventral height and the dorsal height in the thoracic region, now the dorsal height is slightly more than the ventral height. In fact, it said just 0.8 millimeter go on increasing per vertebra. So, that actually adds to the normal kyphotic curve. The dorsal height being more than the ventral height slightly adds to that. Even the intervertebral disc is placed such that the normal kyphosis comes because of that height difference, which is very, very minimal, cannot be noticed. The other unique feature of thoracic vertebra, all of us know, have these facets, the demi-facets for the head of the ribs, and the transverse processes have the facets for the tubercles of the ribs. Then we have, if we look at the lumbar this thing, now the body size, you can see the transverse as well as the APD, both are increasing enormously. Okay. So, looking at the dimensions here, the transverse diameter, that is the width of the vertebra, which in the cervical region was just 16 to 17 millimeter, shows an increase gradual, a steep increase from the C5, and you can see here the T1 vertebra, the width is somewhere around 27 millimeters. Again T2 to T7, the width is more or less not varying much. And again from T7 to T12, there is a steep increase in the dimension, that is around 40 millimeters. And by the time the L5, that is the last lumbar vertebra we have, the dimension goes to around 46 millimeters. So, this is again just to say how the load is increasing on the vertebral body, that is why the dimension has increased. Similarly, the depth also has increased, that is the anteroposterior dimension, not so much as the width, but yes, there is an increase, a gradual increase, and from L4 to L5 maybe there is a little bit of decrease in the depth, that is the anteroposterior dimension, but overall the dimensions are so big that this is not really noticeable. So, the maximum depth which can be seen is around 30 millimeter in the last lumbar vertebra. The vertebral body height, though the graph shows that there is a slight decrease up to C6, and then there is a steep increase in the ventral heights, and in the lumbar region the dorsal height may decrease. But here this graph does not show what I was mentioning, that the dorsal height, as I said, in the thoracic region is slightly more, which adds to the normal kyphotic curve, and here the dorsal height being less can be adds to the lordotic curve of the lumbar region. Now, we come to the pedicle morphometry in these two regions. The dimensions which we are going to see here are the transverse diameter, that is the width of the pedicle, then the transverse pedicle angle, this is the axis of the pedicle and this is the mid-sagittal plane. So, the angle, the axis of the pedicle makes with the mid-sagittal plane is the transverse pedicle angle. The other two dimensions are the pedicle height, okay, and the angle with which it makes with this horizontal or the axial plane, that is the sagittal pedicle angle. Here let us see the pedicle width. So, I have already stressed on the fact that in the subaxial spine, the pedicle width may just vary from 6 to 7 millimeters. So, it is a very, very narrow structure in the cervical region, but in the thoracic region, if we see there is an increase initially from T1 to T2, that is around 7 to 8 millimeters, and then there is a decline. So, the region of T4 to T6, This is the region where there is the pedicles are the narrowest. That is the narrowest region where we have maybe even slightly smaller than this, somewhere around 4 millimeter. Okay. So, the pedicle screws in this region, the leverage is much more less as compared to the other zones. Again, after T6, the depth, the transverse diameter of the pedicle is increasing, maybe around 7 millimeters, and then it shows more increase. And we can see that at T12, this is around 8 millimeters, and up to L5 if we go, the screw can be 16 millimeter wide. The available space is around 16 millimeters for the screw. As far as the pedicle, that is the transverse pedicle angle is concerned, the transverse pedicle angle, which is this angle, in the cervical region we saw that it was 43 degrees. That is, they were convergent. If we look from the posterior side, they were convergent and there was an angle of 43 degrees. A bit of increase in the C4, but then there is a slow decline, and even the region of T1, we can see that the convergence is decreasing now. Okay. And here we can see the angles are just around 25 degrees as the thoracic vertebra. When we go down in the T4 region, the angles, that means now this angulation is decreasing and they are coming more or less in line. Okay. And in the region of T4, the angle, the transverse pedicle angle is around 10 to 12 degrees. Further, and here in the region that is the last thoracic vertebra, the angle may slightly even go to the negative side. Okay. So, that means this convergence is now decreasing and there is a slight -5, we say -5 here, and then in the lumbar region again the angle of the pedicles increase, that is their direction again changes and they again become convergent. So, convergent, a bit of divergence and again convergence. So, in this region maybe that is the vertebra 11 and 12. If we see the vertebra 11 and 12, I don't know whether we can separate it out, we can see that they are more or less in line, the 0 degree angle. The sagittal pedicle width, this is the height or the sagittal pedicle width. Now, coming to the sagittal pedicle angle, this is the positive side and this is the negative side. The cervical region, they are going cephalad, whereas in the dorsal spine, thoracic spine and in the lumbar, especially in the dorsal spine, they are all pointing downwards. They are all pointing downwards. So, if we see the T1, so this angle is around 10 degrees. So, from T1 to T12, T10, T1 to T10, this angle remains in this zone, that is 10 to 15 degrees descending, but after the 10th thoracic vertebra, we can see that this descent is reducing, okay, and slowly they start becoming more horizontal. The L1 vertebra, this is the L1 vertebra, we can see that the angle has now reduced, this downward descent has reduced and the angle has rather become more or less around 2 to 3 degrees, and by L2 and L3 it is 0 degrees. That means the pedicles are attached horizontally to the bodies. Looking at the laminas and the spinous processes, we can see that in the thoracic region the laminas are overlapping. Okay. There is less space in the interlaminar groove, and look at the obliquity of the spines. The spines are oblique, but more so between T4 to T8. After that, this obliquity again decreases, and T10, T11 and T12, the spines have become more horizontal, they are becoming more like lumbar. Lumbar spines again, they are horizontal, broad and thick, so there is space between the interspinous areas. As far as the transverse processes are concerned, they are arising from the junction of the pars and the pedicle. So, when we look in the transverse process of the thoracic region, they are very broad, thick, okay, and they are directed more posterolaterally. So, when we are approaching them from the posterior side, they are more in the operative field because of their direction, they are posterolaterally. But as we go down, T11 and T12, in the T12 we see that the transverse process is hardly there, it is just replaced by 3 tubercles. And from L1 to L4, initially the L1 spine is thin, and is directed more laterally, not posterolaterally. So, this little away from the operative field. L2 and L3 maybe they have a little more wider and longer transverse processes and again laterally oriented, and L5 has though a shorter, but a triangular kind of a transverse process. It is slightly, the shape is different from the L4. The other feature which the transverse processes here in the lumbar region have is the accessory process, which is actually giving attachment to those multifidus and other intertransverse groups of muscles. And this lies just lateral to the process, that is the mammillary process, which is used as actually as a landmark or for the entry point for the pedicle screws in this region. So, it is slightly lateral to the mammillary process, which is on the articulating facets. Coming to the articulating facets, that is the facet joints or the zygoepiphyseal joints, as sir said it. So, in the cervical region we saw that they were directed in the coronal plane. So, coronal and slightly like this. So, that means when we, how many movements we have? We have 6 degrees of movements. So, if the facet is more in the coronal or directed like this, it can have the lateral bending, okay. And if it is in the sagittal plane, then flexion and extension movements are more. And if it is more in the axial plane, horizontal plane, the rotation is possible. So, it is not only one movement, there is always coupled movements because the geometry is such, okay. So, in the thoracic region, because of their geometry now, let us have a look here. Because of their angulations in cervical, they were more inclined at 45 degrees, okay. Now, the first one, the geometry of the C1, C2 were slightly different. So, if you look at all these movements, so this solid line is showing flexion and extension, which we can see is 25 degrees here, reduces again maybe more and then reduces here. The lateral bending is these dashed lines and axial rotation is, we can say, dots, okay. Now, overall we see that the orientation of the thoracic facets is such that all movements are limited. Not only maybe just because of the facet, but there are other factors like the spinous process, they are oblique, the joint capsules are more tight, which are more lax in the cervical and the lumbar regions, the rib cage, okay. So, these factors maybe restrict these movements and even the disc height, the intervertebral disc height. So, what is available motion in the thoracic region is that there is a bit of axial rotation around 6 to 7 degrees, a bit of lateral bending which is again around 5 to 6 degrees, and flexion extension is quite reduced, because definitely they do not have this sagittal orientation to undergo these movements. Whereas, the flexion extension movement, if we see, was much more in the region of the cervical region, where more in the atlanto-occipital joint, decreases at the C2, C3 level, but again in the subaxial spine we see an increase in the flexion and extension movement. Rotation being maximum at the atlantoaxial joint because of the geometry here around 43 degrees. Now, when we look at the orientation in the lumbar region, how they are oriented, they are more sagittally. If you look at these facets, see that they have a more sagittal component and a bit of the frontal, the coronal component. So, that is why the flexion extension movement is much more, around 15 degrees of flexion and extension in the lumbar region. Lateral bending, yes, but axial rotation is completely very minimal, okay, because there is no horizontal component in these facets. Coming to the ligaments, and before that, just this thing about intervertebral disc, all of us know that it is nucleus pulposus and annulus fibrosus, and the annulus fibrosus, which is having fibers directed in oblique directions, they are actually at angles to each other. Every layer has an angulation with each other, and this is designed such that it actually resists all the tensile forces. The nucleus pulposus is designed to resist all the compressive forces, whereas the annulus fibrosus, the orientation of the fibers is designed to resist the tensile forces. Not also this, but if you look at the composition, what are they actually made up of? the water, the proteoglycans and the collagen fibers. So, it is the content which varies in these components. So, water content is more in the nucleus pulposus, so it is more hydrophilic, so can get compressed, okay, and it actually behaves like a sponge. So, the intervertebral disc, it not only like acts as a shock absorber, but it also increases the available range of motion. The facets decide the plane of motion or the kind of motion, whereas the intervertebral disc actually decides the range of motion in a particular this thing. So, if we look at these intervertebral disc in the cervical, thoracic and lumbar region, you can see that this actually the cervical disc are around 3 millimeters, and slowly by the time it is the lumbar region, it is 9 millimeters. But still it is not the thickness of the intervertebral disc, it is the ratio of the intervertebral disc to the vertebral body height. So, this ratio actually decides the range of movement in a particular area, which the ratio is highest in the cervical region, followed by the lumbar region, and then least in the thoracic region. That is why maybe more mobility in the cervical and lumbar regions, and thoracic region is more stable. So, this intervertebral disc, which is actually, if we see in this coronal plane, has 3 components: the nucleus pulposus, the annulus fibrosus, and what we have is here are the vertebral end plates. These vertebral end plates are covering these surfaces, the superior or the inferior surface of the adjacent vertebral bodies, and the vertebral end plates actually have more of the cartilaginous component is much more, and the part which is facing this area has more of fibrocartilage, and the part which is away from here has more of hyaline cartilage, which anyway over the age will get replaced and the entire thing will get the fibrocartilage. The collagen fibers in the annulus fibrosus are more of type 1, and this has more of type 2, again to do with the kind of forces they are resisting. So, type 2 have more ability to resist the compressive forces, and type 1 have the ability to resist the tensile forces here. The vertebral end plates actually, if you see, do not cover the annulus fibrosus completely. It is more peripherally that these fibers of annulus fibrosus are actually joined to this ring apophysis. They find they hold on to the bodies on the sides, and actually if we see, it is not very, when we look at the structure, it is not so easily demarcable. It is only the center part of the nucleus pulposus and the most peripheral part which can be distinguished clearly, but in between there is no clear demarcation in their structure. Also, if we look at the disc in the cervical region, the annulus fibrosus is actually a kind of a concentric ring more anteriorly. It is not covering the disc posteriorly. Okay, so which may be a reason for the disc prolapse in this area is more. Posterolateral deficiency is always more because PLL is protecting it. And if you look at the shape of the disc in the lumbar region, it shows a concavity. So, the annulus fibrosus fibers, if they show this concavity, so they have a more ability to stretch, So, that is why and it can be said is bigger, and here they are more elliptical. So, the posterior stretching is lesser as compared to the lumbar vertebra. And this area is supplied by the sinovertebral nerve. The sinovertebral nerves are nothing but the recurrent branches which are coming from the ventral ramus, which also has the somatic as well as the autonomic component, that is by the gray rami communicantes, which are supplying these parts of the intervertebral disc. So, the disc prolapse, so these are the structures. Apart from the nerves, we do have the arteries in this which get affected. The ligaments, anterior longitudinal ligaments, which are actually thicker opposite the vertebral bodies as compared to the intervertebral disc, but this ligament, if we see, has 2 to 3 layers. They are adherent to the intervertebral disc. If we see, they are in 3 strata. So, the superficial strata which will connect 3 to 4 adjacent vertebrae, the intermediate will connect the 2 to 3, and the deep one will just connect the adjacent vertebra. Now, when the vertebral column is, if we see the extension movements, anterior is running like this. So, what happens is when we extend, so this ligament gets stretched, and when the spine is flexed, this ligament is lax, anterior longitudinal ligament is lax. But if we see during flexion, it is only this ligament which is lax, but all the posterior ligaments, that is the PLL, the facet joints, the intertransverse, the ligamentum flavum, interspinous and supraspinous, they all get stretched. So, extension movement is only limited by the ALL, okay, and the flexion movement is limited by all the posterior ligaments, which are actually the posterior ligament is complex, stretched in flexion. Ligamentum flavum is unique in that it has high amounts of elastin and can be stretched up to 80% without the damage, and is more strong in the lower thoracic and the lumbar regions. Now, if you look at the effectiveness of a ligament, how effective a ligament is, so that depends upon its morphology and its lever arm. Morphology, by morphology I mean the content or the strength, that is, if we measure the failure strength of the spinal ligaments in various zones, that is the tensile load carrying capacity. So, if we look at the ALL, this is ALL, PLL, ligamentum flavum, capsular ligament and cervical region. So, in the cervical region, the failure strength of the capsular ligament, that is the one covering the facet joint, is much higher. So, if this capsular ligament, the failure strength is much higher as compared to the other ligaments. So, it is very important to preserve these capsular ligaments. Coming to the thoracic region, the failure strength of the ALL is much higher as compared to the other. Overall, definitely thoracic and lumbar region, all the ligaments have higher failure strength. In the lumbar region, we have ALL, then we have PLL, ligamentum flavum, capsular and the interspinous ligament. So, this is just about the failure strength. But when we look at the lever arm, that is the distance of these ligaments from the instantaneous axis of rotation, which passes through in the normal condition, which is passing through the posterior part of the vertebral body. So, we can see that the lever arm of the PLL is lesser as compared to the ALL, ligamentum flavum, capsular and interspinous ligament. So, that means a ligament which has a higher lever arm, but is weak, but has a lower failure strength, but its contribution to the spinal stability will be much more because of the longer lever arm. Its contribution becomes much more. So, a very strong ligament that functions through a relatively short lever arm may contribute less to the stability than a weaker ligament which is working through a longer lever arm. So, even interspinous ligament is very important as far as this contribution to the stability is concerned. But in the cervical region, because the failure strength of the capsular ligaments is very high, though it has a short lever arm, it definitely contributes a good amount to the stability of the cervical region.